Hello all. We are starting now our second episode on our scoliosis channel, and this episode we're going to discuss the definition of scoliosis. And scoliosis is a spinal curvature when the spine or the vertebral column crooked with a cup angle equal or more than 10 degrees. But it has to be accompanied by torsion on the vertebra. Torsion, it means the vertebra will rotate on the axial plane. This will torsion vertebra is when we add the growth and time, it makes it instead of 3D problem or disorders, it's a 4D because time and growth are very critical factors when we diagnose and treat our scoliosis patient. So on the frontal plan, the AB view or BA view actually, we have the low curvature, which 10 to 15 degrees. We have the low to moderate, 15 to 25. It's just different division on the according to the cup angle: low, moderate, severe, very severe. It's very important to know where is the curvature site and size. Where is it? Thoracolumbar, lumbar, and we have some key numbers here. When we reach, for example, the 30, most of the author or the literature talk about the Hauter-Wachmann effect, that the progression will be fast. Most of the literature too talking about 45 degree is a surgical threshold. But we're going to discuss all this detail. And one important thing we can see on or obtain on the AB view is rotation of the vertebra. We give it a scale from 0 to 5 according to Nash-Moe rotation, and we decided according to the pedicle of the vertebral body, what the rotation, how much it rotates from the central line. This all we're going to discuss this in detail. Now on the sagittal plan, when we obtain the lateral view X-ray radiology to measure the sagittal profile and judge our balance, alignment, posture, and also it has a lot to do with the pain in the recent literature. We are analyzing our sagittal profile. You want to make sure when you order the X-ray for any scoliotic patient to make the X-ray radiologist specialist to obtain the femur head. Femur head has to be in right there. Femur head has to be on the view, and the reason why, because all our sagittal parameters are connected directly to the femur head. So on the lateral view and our sagittal parameters, of course, we obtain we know the status of kyphosis, lordosis, sacral slope, pelvic tilt, pelvic incidence. Then we do our mass and as a matter of fact, there is a lots of software now allow you to analyze the X-ray both on the AB or BA views and the lateral view very simply. You can use it. It's I don't know if it's free or not online, but it's very simple to use to obtain your sagittal index and fill up all the equation, plumb line, CV to C7 to sacrum, spinosacral angle, and so on. So after the BA view, we have the horizontal transverse axial plan, vertebral, which will determine our vertebral rotation or torsion. On this plan, we can do our rib vertebral angle with measurement, and of course, more than I will say a little bit about it. It's actually the angle between the spinous process here and the two ribs on the same vertebra here, and here. And when we measure this more than 20 degrees, we're talking about we have to check our respiratory efficiency for this particular patient, as this huge angle on the torsion, it will affect the spinal cage, I mean the rib cage, and in sequence it will go and affect the respiratory efficacy. So also we can determine the gibbosity, which is almost the same thing. Gibbosity is the apical vertebra, and it's the torsion that the apical vertebra makes both in the vertebrae and on the ribs. On this particular vertebrae, the gibbosity effect, which is very important to to obtain too. So once we arrive to the age and growth slide here or discussion, we know that vertebral column starts in 20 days interuterine, so it's like roughly 3 to 6 weeks interuterine life, and we have some landmark like 6 to 24, 5 to 8 years, 10 to 13, 12 to 15 years, both in girls and boys, which is a growing spurt on the vertebral column. Menarche is a very critical landmark, as in adolescent idiopathic, in idiopathic scoliosis generally, we have 8 or 9 to 2 to 1 girls to boys. So menarche is a landmark that will tell us, okay, growing is done, ossification centers are closed, there is no more extra spurt on the growth. So just consider this in your equation when you decide treatment on either exercise or bracing or even surgery. We're talking about menarche is a very important thing. Then we have the 45 to 55 years, also for women consideration about the osteoporosis and this particular menopause age. And over 60 years now, the literature talk about all the people over 60 years will develop will develop adult idiopathic scoliosis or scoliosis in some sort. Over 60, it's like 30%, 35%. Over 90, it's like 70%. So even in our elderly people, there is some prevalence and some high number of incidents that happens, and that's what's actually been the last 5-6 years discussion on this particular de novo scoliosis, which scoliosis that happen on the older people. And also we're going to discuss this in detail. So now, how we determine the gross markers in different age? We start with X-ray, of course, A, B X-ray or B X-ray. If you can see the shadow here behind the background here, on this here we have the razor 0 to 5 scale, where the ilium ossification center right there, we go 1, 2, 3, we give degrees for the ossification on the hypophysis of the ilium. That's razor 0 to 5, was a little different between European and USA scale. Then we have razor plus, which we add to the razor, our riser scale, we add the tri-radiate cartilage. If it's closed, it's riser plus, means no more gross will happen in this particular individual. Then we add, there's some other ways to determine the bone growth and ossification and bone age. One of these ways is a humerus head ossification, also stage from like 1 to 4. We have the Girlish Bale, Tanner Whitehouse. Those are dealing with the atlas, comparing the atlas of the hand, wrist and hand atlas, bone atlas, ossification, like archiving, comparing to our case. We have the silver grain. Swap grain also is they dealing with the elbow ossification and centers on this. And definitely we have the secondary sexual feature and characters for both male and female. We use all this gross markers in combination to each other. Some people prefer certain things, but it all works. We just use it as a package to determine our patient age and growth age, and to discuss when we have the treatment and management discussion according to growth and age. Now, the screening is very important. I divided this like level one, the gym instructor at home, just screening at home. Level one, just regular people. General education, general like general people that deals with kids around the age of 8 to 12 group years old. Then we have level two. Of course, the kid can have a school nurse or even his physician or pediatrician and any regular nurse. Then we have level three when the screening say, okay, this kid has some suspicious about uh, scoliosis, so we're gonna give him to a specialist like scoliosis clinician or physiotherapist, and it's all done by the same technique. Either it's primitive or very professional. Adams test, scoliometer, hump. Then we have some numbers. When we reach this number, we order X-ray and we go from there. Then we reach now our last slides. Again, I want to say that this channel is for all scoliosis healthcare provider, physical therapists, medical doctors, doctor of DC, orthotist, surgeon, nurses, and also, most importantly, scoliosis patient and their families. And it's for general public education to fill the gap among different scoliosis clinicians through the scientific literature and research paper. My name is Wa'il Muhammad Abdullah. I'm a medical doctor and a chiropractor, and I'm obtaining the Scoliosis Master on the Italian Institute this year. Thank you, and we'll be discussing next episode. We will go in details on some, I believe we're gonna go for scoliosis types and diagnosis. Thank you so much and have a great day.